third webinar presentation. This is for Project 3.a.i, which is Behavioral Health Primary Care Integration. I'm Heather Bradley, and I'm going to turn the presentation over to Colleen Florio for the beginning section.
Good morning, everyone. Here you see our agenda for today. Today's webinar will provide you with brief updates on governance and project financing, followed by an overview of the current draft of the project implementation plan, which contains two parts: project requirements, steps, and target dates, as well as a list of the project risks and mitigation strategies. We will not be taking questions live today. Please send questions to the DSRIP mailbox. Instructions will be given at the end of the webinar. In addition, we'll provide instructions at the end of the webinar on how to offer feedback on the draft implementation plan that you see today. Let's begin with the governance update. The governance milestones you see here have been set by the Department of Health and are not expected to change. The PPS governance must be finalized by September 30th of this year, also known as DSRIP Year 1, Quarter 2. Following the September due date for finalizing the governance structure, we will then need to finalize a clinical governance structure and process, including establishing clinical quality committees. That step is required to be completed by the end of this calendar year. Into 2016, we'll be working to put together the governance structure, reporting, and monitoring processes. As I said, these milestone dates are not expected to change. They're required dates for all PPSs to reach, and failure to meet these dates would impact the funds flow to the PPS. So, some next steps with governance development. DOH recently released key information in a document entitled Funds Flow and NewCo, meaning new company, Funds Flow and NewCo Requirements. AHI had been awaiting that document for quite some time, and we were not able to finalize governance until we received this important information. It explains to us what we can and cannot do in terms of governance design. What we know now is that the PPS lead entity, which is AHI, cannot delegate any authorities or responsibilities without written approval from the Department of Health. What the lead entity can do is develop a shared governance model to support collaborative decision-making across the 9-county region. What we now know is that for that model to be approved, all aspects of ownership and control must reside with safety net providers. This requirements document also explained that an LLC structure is not an acceptable organizational structure for providing governance. Governance must be with a safety net organization that is a not-for-profit, a 501c3. So some of the next steps, how are we going to get to that September due date, which is pretty rapid now that this document really came out like the last week in June, and here it is mid-July. What we'll be doing is working with the AHI members, this has already begun, with our members, our board, the PPS steering committee, and the regional health innovation team leadership to look more carefully at those requirements that DOH has issued, and as such there'll be a series of meetings in July and August. In fact, steering committee meets next week, and this is a prime topic on their agenda. We've elicited proposals for additional legal consultation to find the right type of legal support that can work with us to make sure that what we establish is in accordance with these requirements and that it's put in place quickly. We do have some responses to that proposal and expect to have that finalized this week. And finally, we will finalize governance by that September deadline. Failure to do so would impact the funding. So now on to project financing. I just have a few brief words on financing, and then I will turn it over to Heather for the more important part of today's webinar. So financing, you see in front of you the finance milestones that the PPS is required to meet. The actual finance structure, including the reporting structure, needs to be put in place by the end of this year. As you know, contracting has not been completed. Well, we were not able to go through that contracting process until we received the information that came out in that funds flow and NewCo document that I mentioned earlier. So that document answered several questions about what is and what is not allowable in the funds distribution. One such requirement is that 95% of the funding flow to or through safety net providers. And here you see a diagram of the funds flow, simply showing that the majority of the dollars flow into once they've been received by the PPS, they then flow out to safety net providers. And in turn, that safety net provider can establish contracts with other types of organizations, non-safety net, for project implementation. So what do we think this will look like? The PPS will enter into performance-based agreements with performance partners. So I mean, these are the safety net organizations that are willing to share risk with the lead. These performance partners must be safety net, but as I said, they may in turn enter into contracts for services, non-performance-based contracts with other organizations, including ones that do not have safety net status. I would anticipate that detailed work plans and budgets would likely be a deliverable in these contracted agreements with the performance partners. A performance partner who's contracting for services from a given organization may ask that organization to show a work plan and a budget as well. But the key point here is that the Department of Health is not requiring, nor is AHI, submission of detailed work plans at this point in time. It is important for you as an organization to develop those work plans and budget out your costs for taking part in these projects. Those work plans will be needed in part so that your own organization is able to manage and provide oversight to progress on that project. So now I am going to turn it over to Heather, who will describe an overview of the implementation plan as well as the draft for this specific project.
Thanks, Colleen. So we're going to look at the requirements and some of the target dates. All of these items have been preset by the Department of Health and can be located in the metrics and milestones document. Just to reiterate, a copy of this webinar and a copy of the work plan will be available on our website toward the end of this week. So we're going to go through the details. We first want you to realize that there's only one next step from this webinar. We're really looking to solicit your feedback. We're looking to find out what your thoughts are on the work plan, if something's not clear, if there should be additional steps added in. Do you think those target dates seem reasonable? So all of that general feedback we're going to have you submit, and the email address to do that will be shown at the end. So first, for behavioral health primary care integration, for both models 1 and 2, the PPS made a commitment to complete all of the required steps by the end of DY4 quarter 2, which is September 30th, 2018. So that's the absolute farthest out date we can meet our requirements. That being said, there are certain requirements the Department of Health is requesting us to complete sooner. So you'll see some of those things reflected in the dates we're going to look at. So we're looking at the high-level steps right now, and there's Model 1, which is placing behavioral health providers into a primary care setting. And then there's Model 2, which is placing primary care providers into a behavioral health setting. For the majority of partners, you're looking at the Model 1. So for Model 1, you're going to be looking to co-locate behavioral health at primary care sites, and those primary care sites must meet NCQA Level 3 PCMH standards by the end of DY3, which is March 31st, 2018. So the first step is to coordinate with Project Team 2A2. Project 2A2 is basically the NCQA certification project. So we have a person who will be working directly with those primary care sites to help them meet that NCQA certification. So we're going to really look to coordinate with that team. We're looking to have the behavioral health services co-located within the primary care sites. Besides co-location, really the push of DSRIP is really more toward integration. So I would ask that you keep that in mind as we're going forward. But the term co-located did come from the Department of Health within this work plan. And then we're looking at coordinating the availability and schedules of behavioral health services to ensure adequate coverage for the primary care patient volume. We want to make sure that there's behavioral health services available to not only meet the volume of patients who need those services, but also that those hours of services are going to match up with the hours of services of the health center if possible, or that those service hours are going to really meet the demand of the patients who need to receive that care. Okay, so the second requirement is to develop collaborative evidence-based standards of care, including medication management and care management by the end of DY2, which is March 31st, 2017. So one requirement is to hold regularly scheduled formal meetings to develop those care practices. And the other is to coordinate evidence-based care protocols for medication and care management. This is really one where we're looking to have you build out more steps and give us feedback. What does coordinated medication and care management look like to you? How do you plan on engaging those services? Are you looking at utilizing health homes? Do you have thoughts on other care management? So we would really like your feedback on this in particular. The third requirement is to conduct preventative care screenings. Specifically, the department had listed out the PHQ screening or the DSRIP. Now, a lot of places are already doing PHQ, and that's great. The question had come up, does that count if we're already doing it? The answer would be yes if you're building on what you're already doing. So I'm going to jump to looking at number 4 on this slide, which is positive screens result in warm transfer to behavioral health providers as measured by documentation in the EHR. What that means is if somebody screens positive on the PHQ-9 for depression, if you're not currently doing a warm transfer to a behavioral health provider, but you then build that into your process because it's required, that would mean that patient screening counts and you can continue to use the PHQ because you're building on what you're already doing. So to jump back up to number 1, we need to create policies and procedures to facilitate documentation and completing the screenings. The screenings need to be noted in your electronic health record, and at least 90% of patients are going to receive these screenings. The other question has come up that the PHQ screening really is indicated for ages 12 and older, and the comment back to that is that if it's clinically indicated for ages 12 and older, if that's documented within your policies and procedures, then that population that you need to do 90% of would be the 12 and older. And requirement number 4 for Model 1 is use EHRs or other technical platforms to track all patients engaged in the project. And the department's requiring that be done by the end of DY2, which is March 31st, 2017. So the EHRs need to demonstrate the integration of medical and behavioral health records. And then the PPS needs to identify targeted patients and track the actively engaged patients for project milestone reporting. Then moving on to Model 2, basically you're going to notice that the requirements are pretty much just a mirror of what was in Model 1. So you're going to be coordinating again for the PCMH NCQA certifications. You're going to co-locate the primary care services within a behavioral health site, and you're going to want to make sure that there's available primary care coverage to meet the needs for the patients. Requirement 2 stays the same. You're looking at medication management and care management processes and making sure that those are coordinated. Again, 3 is still conducting those screenings. They're specifically, again, mentioning the PHQ 2 or 9 screening or using DSRIP. And then 4, again, is the use of the electronic health record or other technical platforms. All right, so next we're going to take a look at some risk and mitigation. So the first risks that we have mentioned is acquisition, implementation, and training on new or upgraded health records. Potential timeline impact is getting all providers or practices on board with EHRs can be time-consuming and can slow down our implementation process. Recognizing that behavioral health providers traditionally have not been incentivized to have electronic health records, it's going to be a heavy lift for a lot of providers to get on board with electronic health records. So we know that this can slow down our timeline, but the move toward electronic health records will really help improve patient care. So our mitigation strategy is that we're going to help assist with funding and making sure that the EHRs that are selected are interoperable, meaning that they'll be able to talk with other EHRs, that the information is going to be usable, we'll be able to pull data so that we can meet those commitments. The next risk is recruitment, training, and retention of qualified staff. Recognizing that we're in a provider shortage area, there can be delays in increasing services or adding new services because we may not have the qualified staff to provide those services. The mitigation strategy, right now we're looking at family medicine residency programs to gain new physicians, possibly looking at some salary supplementation to build internal capacity so that you can get LMSWs up to an LCSW billable license level. And again, really working with our workforce committee will be important. A risk is supervision time for LMSWs. Depending on how many you hire, that can slow things down because you're taking away from another provider's time. Looking again to offset some of the costs for that supervision. Another risk is developing and implementing new policies and procedures around integrated care models. The amount of time to write policies and procedures along with training staff on them can possibly delay starting a project. And really looking to leverage our partners who have some more experience with integrated care or co-located care and seeing how we can best implement those integrated services throughout the rest of our PPS. Integration of primary and behavioral health care when a patient has non-integrated providers is a risk. So potentially just the time to coordinate care between a non-integrated provider could slow things down. Using health home care coordinators to assist with that non-integrated care coordination would be helpful. And then another risk is having time to perform evidence-based screenings during a primary care appointment. And we're looking to see that partners have screenings embedded in their electronic health records to make it easier and more accessible for the providers to do those screenings. A risk is meeting that NCQA certification. And again, we're really looking to have our groups work closely with the Project 2A2 team to ensure that we can timely execute meeting that certification requirement. Medication management, and really working with our providers and with HCSCNE to try to figure out the most effective way to do med reconciliation as a mitigation strategy. SBIRT itself was brought up as a risk because there's confusion over SBIRT and OASIS requirements and what training looks like. Some of our partners have opted to just really focus on using the PHQ-2 or 9 screenings to avoid SBIRT confusion. Others have sought to do additional trainings on what SBIRT is to see how we can really incorporate that. And then another concern is access to specialty behavioral health services. We know that there is difficulty gaining access to those specialty services. We have provider shortages, we have capacity issues. So examining current caseloads and models of care to try to figure out how to reduce wait lists and increase access to those services is going to be crucial. A risk is if CRFP monies are not approved or if they're delayed, and having organizations look at a backup plan or figure out how they can rework their ideas on incorporating changes based on funding is going to be a mitigation strategy. Another risk that was brought up is if you change models of care, you might have increased patient caseloads for psychiatrists. If a psychiatrist goes from having a small caseload to a large caseload, there's a worry that you might lose your psychiatrist to a different organization. So really having buy-in from your current psychiatrist on your model of care change is going to be important. Talking with them, making sure they're on board, and then making change gradually so that you don't overwhelm your current staff is going to be important. All right, and then looking for feedback. So we're looking for feedback on the requirements and those milestones and the dates, as well as risk and mitigation. So if there's additional risks that you identify, if you can submit them with mitigation strategies, that would be wonderful. We're looking to have you send your feedback by July 21st to the DSRIP email, which is listed. It's DSRIP, DSRIP, AHI, @adkhi.org. If you would please use the subject line IP feedback, and that way we'll know how to route it. Along with a copy of today's presentation, the draft implementation work plan in an Excel file will be posted to our website. You have the option of doing edits directly within that work plan and then returning an attachment of that work plan to us if you have multiple changes or things you want to add to the work plan, or you can feel free to do just written comments in an email and send those back to us. So in conclusion, we'd like to thank you for taking time out today to go over those requirements. For some of you, it was a refresher. For some of you, it might have been the first time you really took a look at the work plan steps that the Department of Health had put forward. We welcome your feedback, and we hope you have a great morning.